Hello, welcome to Clinical Case Series. My name is Dr. Olutayo Sogunro, Board Certified General Surgeon. This is Clinical Case General Surgery number 6. We will begin with a history of present illness. We'll move into a case presentation, followed by a clinical discussion. This is a 21-year-old female who presented with neck pain and dysphagia. She had suffered multiple stab wounds to the bilateral neck. She arrived to the trauma bay GCS 15 with minimal bleeding from her bilateral neck wounds. Her pain was sharp. She also complained of some dysphagia. Her past medical history is significant for anxiety, and she had not had any previous surgeries. Her family history was unremarkable. She has a negative social history. She takes Cymbalta and Adderall and has no known allergies. What would you like to do next? How about we review our ABCs for the initial management of a trauma patient? A is for airway assessment and protection. Here you want to maintain cervical spine stabilization when appropriate. B is for breathing and ventilation assessment. You want to make sure the patient has adequate oxygenation. C is for circulation assessment. You want to control hemorrhage and maintain adequate end organ perfusion and gain access in terms of IVs. Disability assessment, you want to perform basic neurological evaluations. And E, exposure and environmental control. You want to undress the patient and search everywhere for possible injury. You want to make sure that you're preventing hypothermia and make sure the patient has adequate temperature control as well. So, now let's move on to the physical exam. The patient's vital signs reveal tachycardia with a heart rate of 115, otherwise, generally normal vital signs. She was awake and alert, a little bit anxious and tearful. She had multiple bilateral stab wounds to the neck, about zero point 0.5 to 1 centimeter wide. 5 of them were in zone 1, 5 of them in zone 2, and 3 of them in zone 3. Heart and lungs were within normal limits. Her abdomen was soft, non tender, and no other deformities seen in her extremities. So, a quick review of the zones of the neck to understand where her injuries were. Zone 1 is the area between the clavicles and the cricoid cartilage. Zone 2 is the area between the cricoid cartilage and the angle of the mandible. And Zone 3 is the area between the angle of the mandible and the base of the skull. She had injuries in all 3 areas, bilaterally. Now, what would you like to do? Prompt imaging of the lateral cervical spine, chest, and pelvis can detect life threatening injuries that might otherwise be missed. A portable x ray, a fast exam, and lab work are all adjuncts to the primary survey. Here's the patient's portable chest x ray. Do you see anything? Her laboratory work. Here you can see she has a slight leukocytosis. Don't forget to check the pregnancy test in women of childbearing age. Hers was negative. So let's move on to our secondary survey. A careful head to toe secondary assessment or secondary survey is performed in all trauma patients, determined to be stable upon completion of the primary survey. The secondary survey includes a detailed history, a thorough but efficient physical exam, and targeted diagnostic studies, and plays a crucial role in avoiding missed injuries. So let's talk about the additional imaging. What would you like to order? This patient got a trauma pan scan, which included a CT scan of her head, neck, chest, abdomen, and pelvis, as well as her dorsal spine. Her CT neck is pictured above. She also obtained a CTA of her neck. Because of the patient's dysphagia, she also received an esophagram. See anything? How about now? What's your differential diagnosis now? If you guessed esophageal laceration with perforation, you were right. So what do you want to do now? Take her to surgery. An esophageal gastroduodenoscopy or EGD was performed and did not find any major injury, indicating that the injury was small. Next, she had a neck exploration with esophageal laceration repair. A tract from a stab wound in the left neck going into the esophagus was noted, which made a hole in the superficial layer of the anterior lateral esophagus. This was repaired primarily, and a JP drain was placed. Next, she had a flexible bronchoscopy, which was performed to rule out any airway injuries. No abnormalities were noted. She was noted to have the pneumomediastinum, as well as a traumatic anterior lateral esophageal laceration as her postoperative diagnoses. Postoperatively, she was managed on the medical surgical floor. She was extubated after surgery and had minimal shortness of breath that day. The first 3 days after surgery, she was kept NPO with IV fluids and antibiotics, as well as pain control, and her JP drain was serous in drainage. On post-op day 4, she had a repeat esophagram that was negative for any leak, and she was started on a clear liquid diet. On post-op day number 5, she was continued on a clear liquid diet and was working with speech therapy. She was ultimately discharged home on post-op day number 6 with a diet of clear liquids for 5 days, then another 5 days of full liquids. So let's go on to the clinical discussion. Let's talk about penetrating neck injuries and trauma. A penetrating neck injury is a neck injury resulting from a gunshot or stab wound or penetrating debris. Trauma is a leading cause of morbidity and mortality globally, with road traffic injuries being the leading cause of death in those aged 18 to 29. Penetrating injuries are responsible for fewer than 15% of traumatic deaths worldwide. Greater than 80% are blunt force trauma. Penetrating neck injuries specifically comprise 5 to 10% of penetrating traumatic injuries overall. They are caused usually by bullets, knives, and other impaling objects such as shrapnel or glass. They're categorized by zones, as discussed earlier in the case. Mortality rates for penetrating neck injuries appear to be highest with zone 1 injuries, those that are below the cricoid cartilage, due in part to the proximity of mediastinal structures, the severity of the vascular injury sustained, and surgical challenges. Exsanguination is the most common cause of immediate death, and the carotid artery is the structure most often involved. Zone 2 penetrating neck injuries are the most common. Those are those between the cricoid cartilage and the angle of the mandible. They are followed by zone 1 and then zone 3 injuries. Pathophysiology is quite simple. It's an injury to the neck that penetrates underlying structures, causing damage. Signs and symptoms include hard and soft signs. Hard signs are the most concerning. Hard signs are those that indicate vascular injury, such as uncontrolled hemorrhage, rapidly expansile or pulsatile hematomas, thrills and bruits, hypotension unresponsive to aggressive fluid resuscitation, absent or diminished radial pulses, neurological deficits consistent with cerebral ischemia or stroke. Hard signs of air digestive injury include air bubbling from a wound, massive hemoptysis, and respiratory distress. Soft signs include those within 1 to 2 centimeters of a major vessel in proximity, in the presence of other soft signs of vascular injury as well, such as minor hemorrhage, mild hypotension, minor hemoptysis or hematemesis, subcutaneous or mediastinal air, a non expanding hematoma, dysphonia, and dysphagia. Workup and diagnosis includes basic laboratory work, in which our concern is for blood loss, a bleeding risk, and need for transfusion. So we want to make sure that we type and cross match these patients and check a PTINR and basic coags. Imaging in patients that are stable with soft signs of injury include a CT angiogram or an esophagram. A CTA or a CT angiogram has high sensitivity and specificity for laryngeal and tracheal injuries. It also has high sensitivity for vascular injuries and can identify pharyngeal or esophageal injuries as well, thereby eliminating the need for multiple imaging modalities to assess each type of injury. An esophagram is very key in a patient that you suspect esophageal injury this patient had with her dysphagia. Procedures such as laryngoscopy, bronchoscopy, and endoscopy are also performed in workup of neck injuries, particularly those of zone 2 injuries of the neck. Now let's review the zones of the neck in detail. Zone designation carries implications for management and prognosis. Zone 1 is the area between the clavicles and the cricoid cartilage. This zone contains vital structures such as the innominate vessels, the origin of the common carotid artery, the subclavian vessels, and the vertebral artery, as well as the brachial plexus, the trachea, the esophagus, the apex of the lung, and the thoracic duct. Furthermore, surgical exposure and access can be difficult in this zone because of the presence of the clavicle and bony structures of the thoracic inlet. Zone 2, this is the area between the cricoid cartilage and the angle of the mandible. The following structures are located here: the carotid and vertebral arteries, the internal jugular veins, the trachea, and the esophagus. This zone has comparatively easy access for clinical examination and surgical exploration. Generally, zone 2 injuries of the neck need to be explored. Zone 3, this is the area between the angle of the mandible and the base of the skull. This area contains the distal carotid and vertebral arteries and the pharynx. Since it is very close to the base of the skull, this area is less amenable to physical examination and difficult to explore during surgical exploration. Now let's review the CT scan of the neck of this patient. On the left is a sagittal view showing air anterior to the cervical esophagus. On the right, you can see a significant amount of air around her trachea and esophagus. This is what prompted us to get an esophagram in addition to her dysphagia. On her esophagram, in this image, you can see that she had contrast extravasation coming out of the esophagus at the level of C3, indicating esophageal laceration and perforation. Treatment for penetrating neck injuries can be medical when the patient is stable and only has soft signs and no indication for emergent operation. These patients can be observed for 24 hours with supportive care. You can start them on broad spectrum antibiotics if you suspect a pharyngoesophageal injury. Surgery depends on the stability of the patient and the type of injury. You always want to get a definitive airway. This can be done by intubation. If you cannot intubate the patient, you need to do a cricothyroidotomy, which can later become a tracheotomy. You want to perform a neck exploration for cervical esophageal injuries, a thoracotomy for mid and lower esophageal injuries. All suspected pharyngoesophageal injuries warrant surgical consultation. If not promptly diagnosed, they can cause mediastinitis, an abscess or empyema formation, and the leakage of gastric contents. Clinicians should begin treatment with broad spectrum antibiotics in all patients with suspected pharyngoesophageal injuries. Post operative close monitoring is very important in patients with cervical injuries. You also want to make sure that you repeat imaging to make sure that the injury is healing. On post op day number 4, this patient had a repeat esophagram, as you can see here, that showed no extravasation. The end. I hope you all learned about penetrating neck injuries and how to initially manage a patient in a trauma setting. If you have any questions, please do not hesitate to reach out. Thank you for watching.